So welcome everyone. This is the second part of our buprenorphine education series for palliative care. My name is Zach Sager. I use he, series pronouns. I'm a psychiatrist and hospice and palliative care doc at the Boston VA. And I'll have our other speakers introduce themselves. Janet, you want to go next?
Sure. Hi, everyone. So I'm Janet. I'm a palliative care doc. I'm in transition from MGH to UCSF and just completed a fellowship in addiction medicine. So happy to be with you guys.
Great.
Hi, I'm Katie Fitzgerald Jones. I'm a nurse practitioner and I work at VA Boston.
So thanks everyone for joining us, and we'll get started. So our objectives today, we'll first start by going over the more classic initiation technique of starting someone on buprenorphine. And then from there, we'll dive into discussing microdose approaches to initiating buprenorphine using both sublingual and the transdermal buprenorphine patch. We will also spend some time talking about harm reduction and how harm reduction might apply in our palliative care setting. And then and then we'll have some cases to share, and then leave plenty of time at the end for questions.
Zach, I saw Jesse and Julie are on, so we should just have them introduce themselves as well.
Absolutely. Jesse and Julie, do you want to unmute yourselves and say hi?
Sure. Hi, this is Jessie Merlin. I'm an associate professor at the University of Pittsburgh and a palliative care and addiction clinician and researcher. So thanks.
Oh, and hi, it's Julie. I'm also at the University of Pittsburgh, palliative care physician and addiction medicine physician and educator.
Thanks, guys. So to get started, we'll have 3 cases that we'll go over today. The first one will be a review of our, covering what we talked about in our last discussion, which was traditional initiation. And then our subsequent 2 cases will be focused on using a microdose regimen. So to kick it off, why don't we dive right in on our first case. And our first case is let me move this first. Perfect. First case is a 43-year-old patient who's been successfully treated for head and neck cancer that's followed by palliative care in the survivorship clinic at their hospital. They have ongoing pain at their treatment site and are currently receiving oxycodone, long-acting OxyContin 30 milligrams 3 times a day, and they really wanting better pain control. They had previously been on a combination of long-acting and short-acting, and have been successfully weaned off of the short-acting with overall not a reduction in their pain quality or an improvement in their functioning with the reduction in opioids. And they continue to rate their pain the same level as before on a visual analog scale. When they have given this individual's status in the survivorship clinic, attempts at and the desire to have this individual on less opioids. Previous attempts at weaning doses have been left the patient with a worsening pain, insomnia, low energy, feelings of dysphoria. And despite this, the patient continues to feel that the current doses are ineffective, that pain is still an issue, and that they also are feeling tired with the restrictions that are put on them because of this medication. And they really just want to feel better now that their pain treatment is done. So, this person is familiar for many of us, I'm sure, who seems like many of the patients we wind up seeing in our outpatient palliative care clinic. And so the clinician does a deeper dive in their chart and finds that looking back through their notes that they had missed several appointments in the last year, and they had requests for early refills during active treatment. And they had also described that they were taking their medications differently than prescribed while on the course of treatment. I will pause and just remind folks to please mute yourself if you are currently not muted. In addition to that past history of taking the medication not as prescribed and early refills, you've noticed that on the recent visits, they seem more irritable when you discuss their pain regimen, and that there are more tensions at home. And their spouse really does not like the fact that they're continuing to be on this medication. So in assessing this patient, one of the first questions is, does this patient have an opioid use disorder? And why do you think so? And so I want to start encouraging folks to write in what they think into the chat box on the side. Would you, and Katie is generously going to keep a tally. And oops, I'm reading the chat as well. And so I can, Kathleen says that maybe this person has an opioid use disorder. Jesse, not sure if they're enough information, but that they're concerned. Other people concerned and not sure if there's enough information. This individual is certainly at risk. And I think that this highlights some of the tensions that we see in our patients, is that often we don't have a really clear sense of what's going on. And that maybe something seems like the individual's at risk, but other parts that might, it might just seem like maybe it's a failure of the medication to help with their pain. And so I think from here, we'll kind of remind folks and take a look at the criteria for opioid use disorder. And this is pulled from the DSM. Another helpful way to think about it is just to think about the 4 C's: compulsion, cravings, loss of control, and consequences, consistent use despite consequences. And if we look at this criteria and think about some of the things that this person has experienced, they had periods of early fills, so maybe that's a escalating use. That their functioning hasn't improved despite periods where the dose was escalated or the dose was reduced. That it seems like that the substance is causing some tension between them and their spouse. And so, these things could kind of position this person as having an opioid use disorder. But again, it can also be tough to tell, especially in folks who are receiving long-term opioid medications. So do folks think that this person would be a candidate for buprenorphine?
I'm also curious, a lot of people said they wanted more information and that it would change their management if this individual had an OUD. And I'm wondering if people could comment more on those responses.
What kind of additional information would you want to see? And you're also welcome to unmute yourself and speak up too. So frequent refills is a concern, yep. Loss of control. Interference at work, and so checking in to see how things are going, just outside of not just their cancer care and relationship with their spouse, but in other areas of their life. And so I think what this speaks to is that often these things unfold over time. And for me personally, when I'm doing this work in palliative care, it's not like that I develop. It's fairly rare that I come into a situation and I know on the first visit or the second visit where I'm like, oh, this person clearly has an opioid use disorder. It's usually an accumulation of things over time that lead me to think, okay, what we're currently doing for this person isn't working, so maybe I need to think about this problem differently. So, is this person a candidate for buprenorphine? I would say yes, which is why it's our first case. And there's a couple things that lead us to think that they would be. Certainly the fact that the current regimen is not working for them, that when they were on more opioids, they didn't have an improvement in their symptoms, that and even a reduction in the medication seemed to lead to problems to them. So, this is making me think that maybe full agonist treatment for this individual is not the best. What other factors are going to guide your all's decision to start buprenorphine initiation? What kind of things are you thinking about as whether this person would be a candidate or not? And go ahead and type those factors into the chat box. Yeah, Trish brings up prognosis. So that's a really important factor. Is this person going to live long enough to really benefit from a change? And also, is the patient willing? That's a really important one. We know that the forced tapers, especially in a situation when it's unclear if the individual has an opioid use disorder or not, that there's not evidence behind forced tapers. Also thinking about insurance coverage, if this is, will it incur additional costs for the patient? And then what are other things that you could use? Is methadone an option? And I think the point about methadone is an important one, because I think that often in palliative care, we'll reach for methadone because we're used to using it, but that also, the guidelines about using methadone for an opioid use disorder are very different than how we use methadone for pain. So that's also a tricky area. And then thinking about other comorbid substance use in this individual is important. Are there other things that put them at risk? So these are all really good things to think about that are going to impact whether you are going to start buprenorphine with this patient. And also, do you have a system in which that you can make this work? So do you have your waiver? Do other clinicians in your practice have a waiver? Are you in a system where they support this kind of work? So if we're going to start this person, we've made the decision that we're going to start them on buprenorphine. They're currently on oxycodone extended release, 30 milligrams, 3 times a day. How are we thinking about using the traditional initiation approach and starting this person on buprenorphine? What kind of things, what's going to be your approach as a clinician if this person's in your office? What are you going to tell them how this process is going to work? Go ahead and type it into the chat. Or you can also unmute yourself if you want to say something out loud. Yeah, so some responses that you have to stop one before you start the other. That you have to experience withdrawal symptoms with the traditional initiation approach, correct? And so you're wanting to make sure that the individual is going to be prepared for withdrawal symptoms, which also often means making sure that they have plenty of symptomatic medications available at home, if they're going to do this at home or in the clinic. All really good points. Discussing the benefits, the initiation method, so making sure that you're really doing a good informed consent about making this switch. And also thinking about who's going to call and who's going to follow up with them after they leave the clinic. These are all really good responses. And we take the same approach. And so if you're and generally with the initiation, with traditional initiation, you have to stop the full agonist, wait for moderate withdrawal symptoms, and then start the buprenorphine. And there are multiple ways to do this. One is just to say, let's just, you can stop it now. We'll wait for withdrawal symptoms and then start the buprenorphine. You might elect to taper the buprenorphine slightly if the patient can tolerate it. But knowing that this person's still going to have to go through withdrawal symptoms in order to start. And then if you decide to taper the dose, you have to make a decision if you want something you want to do quickly, or if you want to do the taper longer. Some of the things that we discussed or thought about was with rotating from a long-acting to buprenorphine, you would have to probably wait longer before withdrawal symptoms appeared. And so the patient has to be prepared for that. So that might be a factor. So, what you might want to do is consider having those final doses of the full agonist be a short acting. So maybe the withdrawal symptoms might start sooner. And just as a reminder, here's the COW scale showing what are the withdrawal symptoms that we're looking for. And again, a score of 13 to 24 is moderate, but I have induced people who have had a lower score, especially when they're coming from a full agonist. And so I'm usually trying to get people around 10 or 12 seems to be the magic number for me before I initiate buprenorphine. And you'll start with a test dose. Often a 2 milligram buprenorphine dose to make sure that they don't have, that dose doesn't precipitate withdrawal. And then you can always add a second 2 milligram dose. On that first day, you're generally trying to get them to be 8 milligrams over the course of 24 hours. And then you can increase over the coming days. So before we dive into talking about micro inductions, I wanted to just briefly go over some harm reduction principles, because this work with using micro induction is really grounded in harm reduction principles and harm reduction techniques. And buprenorphine, the use of buprenorphine, the use of methadone, the use of these treatments are also harm reduction techniques. So, harm reduction, this is a definition from the Harm Reduction International. That harm reduction refers to policies, programs, and practices aimed at minimizing the negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. So what we're not doing is we're not singling out that drugs are bad, that we're really focusing on the negative impacts of drug use. And it's important to remember that the negative impacts of drug use are often because of the system and the society that an individual exists in, and the way that we think about drugs, the way that we think about the development of drug policy and drug laws. And so harm reduction is grounded in justice and human rights, focuses on positive change and working with people without judgment, coercion, discrimination, or requiring that they stop using drugs as a precondition of support. I think we can all think of instances when we have seen or have had clinicians say, well, in order for me to treat them, I'm going to require that they stop using drugs. The second quote below is from geriatrician at NYU, Ben Hahn, from a paper he wrote a couple years ago, and describes the overlap with harm reduction principles and geriatric medicine, and thinking about what our typical patient population looks like. So harm reduction is grounded in humanism, pragmatism, individualism, autonomy, and incrementalism, aligned with the guiding principles of approaching older patients with multimorbidity. And both fields emphasize shared decision-making. So I think that this has important parallels with our work in palliative care. Here's some additional information on harm reduction, and similarities about how harm reduction and when we're talking about people who use drugs in palliative care would align. Certainly in palliative care, we care and value and respect patients as individuals and value and respect their decisions. We understand that health behaviors don't occur in a vacuum, especially for our patient population. Abstinence often doesn't make any sense, and it might not be the patient's goals. And at the bottom here, I think it's important to note that harm reduction doesn't just stop at the bedside. And so, what are you doing in other parts of your life in order to support policies and laws that provide humanistic care for people who use drugs? And it's important to note that harm reduction has been increasingly medicalized. We're all clinicians sitting here talking about it. But the movement really developed by and for people who use drugs. And the harm reduction movement, even though it's been going on for decades and decades, we can trace some of the modern harm reduction movement to the beginning of the AIDS epidemic in the early 1980s. And they started to identify AIDS cases in people who use drugs in addition to men who were having sex with men in 1981. And some of the initial work, there were needle exchanges, illegal needle exchanges set up in New York City. This was set up by people who were using drugs. It wasn't set up by law enforcement or clinicians. And so that this movement really was generated from the ground up. And that the beginnings, the palliative care were also, so many people in palliative care became interested and driven to pursue this field because of what they were seeing during the AIDS epidemic as well. So there are some parallels here. I'll hand it over to Janet, who's going to take it next sections.
Awesome, thank you. Let's see.
I can stop sharing and then you can.
Did that work?
Oh.
Did that work?
Yeah, no, I'm seeing someone else's screen. Hold on, I will. Hold on a sec. I'm gonna stop while sharing. Okay, so go ahead. You can share your screen now, Janet. Yeah. There we go.
Yeah, awesome. So, practically from a clinical standpoint, how can we further embody or apply some of these harm reduction principles? I'd say one of the most important things that I've found myself doing more in palliative care is to really help destigmatize addiction and opioid use disorder, substance use disorders in general as a disease, and to be pretty conscientious when I'm talking with patients who are concerned about developing an addiction when we talk about opioids, in using language that is conscientious and destigmatizing. Because the truth is that with the prevalence of opioid use disorder and kind of the overdose epidemic, a lot of patients will either have a personal experience or know family or friends who do. And so it's the chance to provide a little empathy and a little bit of education. One other actionable item is prescribing Narcan, asking patients if they have Narcan, just discussing it so that they know what it's used for. And I talk about it probably as you all do in the same way that we talk about an EpiPen. So you just have it there. The plan is that you'll never need it, and the hope is that you'll never need it, but just in case you do, you have it either for your family or friends or for yourself. And then in line with kind of respecting where patients are, it's really using motivational interviewing to figure out what their goals are, especially if there is some opioid misuse or opioid use disorder that you're concerned about, just getting a sense for where they are and how that experience is for them, and helping them develop their own goals and approaches to getting to a better place. And that's where your clinical experience can help guide that. Lastly, if you do have a patient who does use drugs, and especially a patient who uses IV drugs, there are a lot of harm reduction actions that can be given to patients. So education, and a lot of this involves asking them about whether they know about local resources to get clean works or clean supplies like needles, tourniquets, alcohol wiping pads, getting a sense for where they inject. There are safer sites, there are less safe sites like the neck and the groin, things like that. Knowing whether they've had a history of accidental overdose, whether they've used Narcan before, whether they've had Narcan used on them. These aren't things that we necessarily as palliative care clinicians need to get into the weeds about, but just to know that there are harm reduction educational pieces that patients who actually are actively using drugs can tap into. And this might be where you refer them to someone with additional addiction medicine training. So, oops. Great. And so the bulk of our talk today is really introducing microdosing. And it seems like our group is pretty familiar with buprenorphine as an opioid, but just to make sure that we're all on the same page in case there are folks who are new to the webinar or still could use another refresher like I do myself. So major unique features of buprenorphine and how it differs from other opioids and why we need to be particularly cautious or conscientious when we're thinking about starting someone. So as you know, buprenorphine is a partial agonist, meaning that if you look at the graph on the left, in contrast to this green line, which is a full agonist like morphine or methadone, there's a dose-dependent response. And so the higher the dose of the opioid, the higher you have opioid effects. And buprenorphine, in contrast, has a ceiling effect. And so the more that you give after a certain point, does not increase the total opioid effect, and you have this plateau. And that applies to things like analgesia and euphoria, as well as to adverse effects such as respiratory depression or sedation. And so this unique combination really allows it to have a particular niche in treating patients, both for opioid use disorder and possibly within palliative care, or I would say definitely within palliative care. So in addition, buprenorphine has a high affinity for the opioid receptor, which means that when it's in the same setting as other full agonists, which have lower affinity for the receptors, it will outcompete them. So it will bind preferentially to the opioid receptor and exert its kind of partial opioid agonist effect. It also, once it does bind to the receptor, have a very slow dissociation. So it has a long half-life, around like 24 to 36 hours. And this is what allows for, stability in treatment of opioid use disorder. This is what allows it to act as a long-acting opioid medication, and to even allow for bup dosing every 72 hours in some cases if needed. So all this together means that if you have somebody who's on a full agonist and you add buprenorphine, there's the risk for precipitated withdrawal, because you're taking somebody who's at this kind of full agonist load, and then the buprenorphine is going to outcompete that and drop them to this partial opioid effect. And this is going to feel like withdrawal. And so when we talk about the classic initiation, as you all mentioned, if you have somebody on full agonist feeling that full opioid effect, you have to kind of wait till they feel withdrawal symptoms. And then when you add the buprenorphine, it's going to feel like a step up, and they're going to get benefit from having additional opioid on board. So kind of like we had touched on, there are multiple challenges to the traditional initiation method. And one thing that is particularly pertinent to patients in palliative care is that in waiting for that initiation where you have to come into withdrawal, not only is withdrawal pretty distressing, but it will exacerbate any underlying pain. And we know that, up to 80% of our patients in palliative care have some sort of pain. So this can be a lot of distress and anxiety that's added to a patient. Patients who previously transitioned to buprenorphine might have some trauma from that prior experience or hesitation to go through that again. So they may kind of decline the opportunity to transition, tapering the full agonist to get people to a place where they can feel withdrawal. Can also be destabilizing from a mental health or a physical health standpoint. And waiting for withdrawal, this time period, waiting and letting symptoms build up and cravings build up can actually be a particularly vulnerable time, especially for patients who are at high risk for using non-prescribed medications. They might return to use during this time for instance, if they had been on methadone and had been stable on it, waiting for withdrawal could trigger them to return to use, and they're at higher risk for overdose during that time. And then the last thing is, I think as Jesse had mentioned in the chat, a lot of bup induction or initiation through this method can be done at home, which makes timing a little bit easier, but it does require also that patients have, a stable home environment, that they have kind of organization and the ability to follow directions and to follow the timing of it. For office-based inductions, depending on what they've used and how long you're going to wait for that withdrawal, it may be tricky to coordinate that with a patient coming into your office. So is there a different way? And there is, and this is the microinduction method. So this is based off of a paper that was published in 2010, where the Buprenorphine method was proposed. And the hypothesis is that if you repeatedly administer small doses of buprenorphine with enough dosing interval in between, this should not precipitate withdrawal. And this is based on research or based on a report where patients on full agonists that were given like 0.2 milligrams of IV buprenorphine did not experience any withdrawal symptoms. And so the top kind of row shows what we just discussed with precipitated withdrawal. So you're going from a full agonist, which is the orange, adding buprenorphine, which is in the blue. It has a higher affinity, so it's going to kind of displace the orange, and then people are going to go from this orange level, this high level of opioid effect, to this blue mid-level and feel pretty crummy pretty quickly. With this idea of microdosing or bridging, people who start out with full agonists are going to be given just a little bit of buprenorphine in the background, so not enough to really cause high levels of shifts from dissociation. And as the full agonist naturally dissociates from the opioid receptor, it's going to be filled in preferentially by the buprenorphine because of its higher affinity. And so slowly over time, over a number of days, because of the long binding time of buprenorphine, it's going to slowly accumulate and replace an increasing amount of the full agonist. And what this allows us to do is to initiate buprenorphine in a way that's independent from full agonist dosing or type or timing. So it can really happen at any time. And then the same authors in Switzerland published a paper in 2016 that was kind of a proof of concept, where they had these two patients that transitioned onto Suboxone using microdosing. The first is a patient who was using 3 grams of IV heroin, and over 9 days, starting with a bup dose of 0.2 milligrams, that started at the same time while she was still using heroin. Over the 9 days, there was essentially a cross taper where the bup went up and then the heroin kind of came down, the heroin use came down. And then there was another patient, this 49-year-old gentleman, who was on quite a large amount of opioids, so a high OME, essentially 200 milligrams of heroin agonist treatment for OUD, IV twice a day, plus 40 of methadone once a day, stable on this regimen for 6 years for treatment of OUD. And then over the course of 30 days with microdosing of Suboxone, was able to transition successfully without any withdrawal symptoms. And so again, just to note for him, his bup doses were increased stepwise from 0.2 to 0.4 milligrams of BNX, which is the buprenorphine or Suboxone formulation. So this second case took a lot longer, 30 days, just because they were a little bit more conscientious about not destabilizing him when he was on such a high amount of full agonist and had such a long period of remission from his opioid use disorder. So not destabilizing him and not causing precipitated withdrawal. And these two cases essentially show that, the concept of microdosing can be actualized in various ways. And there are different regimens that can be personalized for different prescribers, clinics, and different patient situations. There are a lot more reports of different regimens now. And so if you kind of did a search, you'll find different regimens. And really you can tailor it to whatever works for you. It can also make it a little tricky to decide how you're actually going to approach this. And so the key things to remember are that, you know, the typical starting dose is low. They use 0.2 milligrams in Switzerland, but it's a little bit, they had that specially formulated there. And so what's often done in the US is to start at 0.5 milligrams of buprenorphine. So it's 0.5 milligrams of Suboxone. And you can do this by cutting up the Suboxone strip. So you just have the patient, you prescribe a 2 milligram Suboxone strip, have the patient cut that into quarters within the package so the medication doesn't rub off. And then each of those quarters is now a 0.5 milligram dose of Suboxone. Two of the regimens, which we're going to go into a little bit more detail, are one, which is Suboxone microdosing or bridging over a week, and then also microdosing or bridging using the buprenorphine transdermal version, either to Suboxone as an endpoint or to continue on Butrans or transdermal buprenorphine as an endpoint. These other regimens down here we're not going to talk about, but you'll see when you look up regimens that there are longer and much shorter microdosing regimens that are available. The rapid ones happen in inpatient setting only. This is one example of an outpatient microdosing regimen. It's a case report from 6 patients, none of whom met the criteria for opioid use disorder, all of whom were on long-term opioid therapy for pain. So this works in patients with chronic pain as well. They all transitioned successfully to Suboxone through microdosing. And so just to point out with this regimen, they started a little bit higher. So 0.5 milligrams twice a day of Suboxone. This person happened to be on 80 milligrams of OxyContin 3 times a day. So similar to our first case. And what you'll notice again is that it takes, almost a week of slowly doubling up the Suboxone. Usually when you get to this point around, 6 milligrams or so of Suboxone in a patient with chronic pain, based on what cases are out there, that's when the full agonist can start being tapered down. And then you would continue to up titrate the Suboxone or the buprenorphine to meet the symptoms. So all 6 patients successfully transitioned. They do note that their clinic had a nurse contact with every single patient every day during this transition, just to ensure that they could provide support, encouragement, troubleshoot. All right, so one other example of a Suboxone microdosing regimen. This patient is 63. She has a history of chronic low back pain for which she was on Suboxone 24 milligrams daily, and actually presented to an outside hospital with hypotension, altered mental status, found to have this large right-sided abdominal hematoma, transferred to MGH under our care for surgical evaluation and management. So initially, when they presented, their Suboxone was held on admission by the responding clinician, who was unsure whether this patient needed any surgical or IR intervention, which they ultimately did not. Just a side note about this is that you don't actually need to hold Suboxone for a patient who is anticipated to need some intervention or who is anticipated to have acute on chronic pain or acute pain. You can continue with the Suboxone and you can add full agonist on top of that. You can lower the Suboxone dose actually a little bit to allow a little bit more wiggle room or more room for the full agonist to exert its effect. We can talk about that a little bit more in the future, but by not holding the Suboxone, it would actually make it easier for the patient to transition back to their home dose before discharge. Regardless, this patient had escalating pain over the week at the site of the hematoma. They were on this regimen of hydromorphone, 12 to 15 milligrams orally every 3 hours PRN, which they were essentially taking 15 Q3 around the clock. And for breakthrough, IV hydromorphone to Q4 PRN, which they were also taking essentially Q4 around the clock. And so you'll see that over the time that they're here, they were essentially constantly around 600 to 720 milligrams of oral morphine equivalent. their goal at the end of all of this was to resume Suboxone. They were fearful of pain in the classic initiation process, which is how they initially got onto Suboxone. And that's particularly relevant because they're having this acute pain kind of stressor as well. And so they were open to the idea of microdosing while they were inpatient. So the key is to kind of start low and go slow so that you don't precipitate any withdrawal. This is the regimen that they were on. And it's actually the regimen that has now become the standard regimen at MGH, such that there's an EPIC order set actually detailing this microdosing schedule. So she was started on 0.5 milligrams of Suboxone on day 1, and then continued on the full agonist regimen for the duration of the bridge, right? So you want to continue the full agonist while you're slowly building up the Suboxone so that you don't send the patient into withdrawal. If you taper off the full agonist too quickly before the Suboxone has reached a therapeutic level, the patient will feel withdrawal symptoms. So over the course of 6 or 7 days, the Suboxone was slowly doubled. So 0.5, then 0.5 BID, 1 BID, 2 BID, 3 BID, etc. We stopped here at this 4 milligram BID dose and maintained that for a couple days, just to help facilitate pain control. And then once that was in a better, more stable place, over the last 2 days of her admission, when she was getting ready to go home, we were actually able to up titrate the Suboxone over the 2 days and then just kind of taper off relatively quickly the hydromorphone and send her home without any hydromorphone for discharge. One thing that I'll note about this inpatient regimen is that, you know, to get to the 0.5 milligram buprenorphine dose, it does require cutting the Suboxone strips. And that caused some safety reports because nursing appropriately noted that on the film package, it says, do not cut the strip, even though we know that it's safe and that people do that. And so this generated kind of an interdisciplinary meeting between nursing and pharmacy and medicine, addiction, et cetera, to come up with an educational plan as well as an EPIC order set. And I think pharmacy is working on a kind of a microdosing packet where things are already pre-cut for administration on the floors, just to make that a little bit easier. All right. So the takeaways for microdosing and kind of with Suboxone is that microdosing works to transition people on full agonist onto buprenorphine with fewer withdrawal symptoms, and in a way where the timeline is up to you and the patient and doesn't depend necessarily on what opioid regimen that they're on. Start low and go slow. So most regimens will recommend 0.5 Suboxone once a day, and start from there. Typically, the go slow part is that it'll take about a week or so of slowly building up on the Suboxone before the full agonist comes off. Number 3 is that you continue the full agonist during the transition to ensure that the patient has that same opioid load and isn't going to be kind of put into withdrawal. And then the last thing, the timing of when you cross taper off the full agonist, there's no clear guidelines on that. We don't have enough evidence to say that at the Suboxone dose, we can take away the full agonist. And so this really depends on the patient context. For a patient with OUD, you know, we have some guideline in knowing that Suboxone at the minimum effective dose is recommended at 12 milligrams, but most people end up on 16 to 24. So generally you'll have patients with OUD get up to that level of therapeutic effect before coming off their full agonist. If it's somebody who's using like heroin or kind of non-prescribed medications that they buy on the street, and there's unclear formulations or dosing within that, sometimes people will get prescriptions for full agonist via the pharmacy, just to know exactly what they're on so that they don't have any withdrawal. For patients who are doing this transition that don't have OUD and have chronic pain, the timing of the cross taper off the full agonist is likely at lower doses, and usually happens somewhere around 4 to 6 milligrams of Suboxone. So once you get up to that level, you'll see that most regimens start having people come down on the full agonist just to see how the Suboxone works in their body, and then to continue to titrate up from there, since you don't know what endpoint you're going for. So I'm gonna turn this back over.
Okay. Great.
Hey, Zach, this is Jessie. Can I just make one quick comment?
Absolutely.
So I wanted to go back to something that you talked about when you were talking about making the decision to initiate buprenorphine. So earlier in the talk.
Mm-hmm.
So I just wanted to make the point that, you know, for sure, forcibly tapering people from opioids who are doing fine, and there might be some concern about, you know, whether their dose is causing them to be at increased risk, is certainly not advisable. That having been said, I think the case you presented is a little bit different than that, right? And so I just kind of wanted to point out this nuance that when people have either you're concerned that they have opioid use disorder, they start looking like they're meeting the criteria like this guy, or even if they're just taking their opioids in a really unsafe way for whatever reason, I think it's perfectly appropriate to say to them, this is no, you know, this is no longer safe, and we're going to need to make a change. I think it's okay to be, I don't view that as being paternalistic. I view that as just being like kind of what I'm comfortable doing and what I think is appropriate to do for the patient. And so, you know, I find that a lot of times when I introduce the idea of buprenorphine, especially when I talk to them about microdosing, people are pretty open to it. And so I don't often have to kind of, you know, feel like I'm forcing their hand, but sometimes I do. And I think that that's okay to do under the circumstances that I mentioned. So I just kind of wanted to put that out there for discussion, or, you know.
I totally agree. And I think that when it becomes clear to me, and sometimes I would say that sometimes it takes a while for me to really grasp at what I'm seeing as an opioid use disorder. But
for sure,
when it's clear to me that there's someone, that this person, I think they have an opioid use disorder, then at that point it doesn't make sense to treat an opioid use disorder with a full agonist like oxycodone. And I agree, and it seems it's both not safe and doesn't seem like good. It's not standard of care for someone with an opioid use disorder. I'll just acknowledge that, like if I have my psychiatry hat on, I feel good about that decision. But I think a lot of the things that we're taught in palliative care sometimes make that harder. And so I have to always like actively be aware that no, what I'm really seeing is something that I can treat and address, and I think I can do a better job of what I'm doing than I can now.
Totally. And I think sometimes as palliative care docs, we, you know, we want to please people. I mean, I think as physicians in general, we want to please people, but especially as palliative care physicians, we want to do what the patient wants us to do. And there are those times, like you said, putting on your psychiatrist hat or my, you know, addiction medicine hat, like there are times when that is not an acceptable way to go. And so having those conversations with people compassionately, using our palliative care compassion skills, I think is really an important thing to get into the practice today.
And I totally echo your point that these conversations are not as hard now that we're using these microinduction techniques, because we can get people good pain control and not have to have them go through withdrawal symptoms. So it seems much easier than it did a couple of years ago.
For sure that, yes.
And Kathleen brought up a good point, which is very rarely do I have a patient excited about buprenorphine. I think, you know, sometimes people are able to recognize the suffering that their use disorder is causing them in their life, and other times they're just managing a lot of cravings. And so I agree that these are hard conversations, and sometimes buprenorphine is the only thing I'm comfortable prescribing, but pretty often, several months down the line, people are grateful that you helped them come to that place.
Yeah.
And Kathleen's the exact same. Very many times patients are very grateful after the fact.
Totally.
Absolutely.
So let's spend some time closing and talking about butrans, using butrans, and just like it was mentioned in the chat, one of the positives of using butrans is you don't have to cut the film, which will seem like is often a sticking point. So this is a patient who. Oops, let me move this.
All of them about open the same. I'm just wearing these. All right, but it doesn't matter with her.
So, and also just remind folks that there's someone else who's unmuted. This is a microdosing case using transdermal buprenorphine. So this is a 73-year-old veteran with a history of opioid use disorder that was really in the context of being in Vietnam. That's also a point to say that using opiates in Vietnam was incredibly common. I think upwards of 30 or 40% of folks had experienced using opioids while in Vietnam. And then that rate dropped to about 5% upon returning home. So it was a situational thing. So whether that counts as an opioid use disorder or stresses of combat or boredom is still up for debate, but this is something that I see pretty commonly. This person has a service-connected illness for a back injury sustained in Vietnam. They also have non-small cell lung cancer, chronic pain, and their PCP has been prescribing opioids for years, but a recent change in their PCP, they started doing urine drug screens and it popped positive for cannabis. And the new PCP started to taper this person off their long-term opioids. And this individual started to do a lot worse with the taper. They were more moody, more irritable, more down, started to express some kind of vague suicidal ideation that was driven by pain. And then as they tapered, they were continuing to use their opioids that were prescribed at the levels they were prescribed before. So then the person also began drinking again, which they hadn't drank in a number of years, and still reporting high levels of pain. And so he was referred to palliative care, not because of the problems around his pain, but because now he was saying they didn't want any sort of cancer treatment. So they referred him to palliative care. And so the first challenge was really me trying to figure out, like, is this an opioid use disorder? Is this popping up only because like the person was tapered and was doing fine before? It was kind of hard to tell with the records. And then, was the cannabis use really that big of a deal? And I know that I also live in a state where cannabis is available both with a medical card and recreationally. And so that creates a challenge for clinicians. So I wind up taking over prescribing of this person's opioids, and initially thought, well, maybe this is just poorly controlled pain. So put them on what I thought was a more appropriate, more stable regimen. And we did have several instances where the person requested an early refill. Their pain rating, despite changes in doses, did not change, and their function was unchanged. And it seemed that over subsequent visits that the person was increasingly focused on the opioids and where he was getting them. And that also came out in a visit that he was taking some from a neighbor. And he just didn't seem like himself on some visits. So it took some time, but it became really clear to me that this person had an opioid use disorder. What became hard was that when we talked about approaches to initiation, that this person was adamant that they didn't want to go through withdrawal symptoms. And for them, going through withdrawal symptoms immediately brought them back to the last time that they had experienced this, was when they had been using opiates while they were in Vietnam, and then began to experience withdrawal when they were coming home. So I didn't really want to have this be initiation to be a trigger to this really negative past experience. So this is also an important point to remember, that both pain and PTSD symptoms perpetuate one another, and that pain can serve as a potential traumatic trigger for previous events. So, together we decided that, a rotation to a buprenorphine product I thought would help the person have better pain control and better control of their life, and that we would do a microinduction so that they didn't have to experience distressing withdrawal symptoms. We decided to do the patch because I thought it would be easier to manage for the patient at home than having to cut doses. And I was also a little concerned of some level of cognitive impairment. So I thought just like having a patch on this person would be less for them to worry about. So luckily they were already on a pretty low dose of the oxycodone when they saw me. And the general approach was that you can continue to take your oxycodone. I'm going to prescribe a low dose of the Butrans patch. Now, in the United States, the Butrans patch is available in a 5 microgram, a 10 microgram, and a 20 microgram patch. The 5 is really used for people who are opioid naive. The 10 and 20 are for folks who have been on opioids. And so because this person wasn't on a lot of opioids to begin with, I started with the 10 microgram patch. It basically said to them, and I had this recognition that they were probably going to take the oxycodone however they wanted when they went home. And they still had about a week's left of the prescription. And so I said, put the patch on this evening, continue to take the oxycodone, but over the next week, taper it down as you're able. I will follow up with you on Monday morning and check in and see how you're doing. And if you seem to be doing okay, then we'll start to add in sublingual buprenorphine, which I can overnight you in the mail. And that's one of the things that we can do in the pharmacy, and also because buprenorphine is Schedule 3. So they put on the buprenorphine patch. When I called on Monday, they said they had cut back their dose to 5 milligrams 3 times a day. And then at that point, I sent them additional buprenorphine sublingual tablets and instructed them to start that in the morning and to continue to cut back on their oxycodone. The next day, they were able to successfully stop the oxycodone while increasing the buprenorphine to twice a day. And we kept them at that dose for a while. And when I would check in, he seemed to be doing okay. Pain, still had pain, but wasn't worse and didn't have any withdrawal symptoms. And so we put on, at a week, we put on a second patch and I increased this Suboxone to 8 milligrams twice a day. And then he said after about a week and a half, he said he was doing well. He seemed better on this phone. I spoke with his family member who said that he seemed more like himself. So we took off the Butrans patch at that point. And he remained on 8 milligrams Suboxone twice a day. So this person did really well to start. They seemed more like themselves, less confused, and family agreed. But even on Suboxone, I started to notice that there were some requests for early refills. He seemed confused at times, and it was just kind of impulsive. And it wasn't clear to me if this was because he wasn't on a high enough dose to control cravings, or if it was more that he just had this medicine there and he took it because that's what he was going to do. So we trialed a higher dose of sublingual buprenorphine, but it really didn't give any change in his pain or not. And we kind of ran into this cycle where I became really unclear of what he was taking at home. He would sometimes be confused. His family was worried about him. So we ultimately decided to go back to transdermal buprenorphine and take off the sublingual, just because I wasn't 100% sure about what was going on in the home. And so we did that. We increased the patch. I put the patch back on, put the 20 microgram patch. We stopped the sublingual buprenorphine, and that's where the patient stayed now for going on 4 months and has done really well with this. So this is an example of both where there's 2 things going on. There's chronic pain, there's an opioid use disorder, then there's this added layer of some level of cognitive impairment. And I'm using now the transdermal buprenorphine patch for the indication of pain. And it would then also be an off-label indication of opioid use disorder, although I really think now what I'm treating is more kind of pain and impulsivity. So this would be an approach for using transdermal buprenorphine, a rotation onto sublingual, if you don't count this last step of rotating them back.
Zach, can I just say something real quick?
Yes.
This is Jessie. I have no evidence to back this up, but I have heard that, you know, if you get yourself into a situation where you really are treating opioid use disorder with Butrans, or really anything other than Suboxone, you can kind of get yourself in trouble. So, I have no evidence to back that up because I've not done that and then gotten in trouble or known anybody who has. And I also think sometimes, you know, in the palliative care world, people are maybe hesitant to get their waiver and try to use Butrans as a workaround. And so I think this particular case is very unique, but I would just kind of make the point that I wouldn't recommend, I'm not saying you're saying this, but I just want to make sure everybody understands that Butrans is not, you know, the way to treat an opioid use disorder. Again, I'm not saying that's what you're saying, but I just kind of wanted to make that point. Do you agree?
Yeah, I totally agree. And echo that it felt, and I will say, like, and I had to do an extensive amount of documenting and discussion with pharmacy to like make sure that everything was on the up and up, because I did feel uncomfortable because I felt like this person had an opioid use disorder, but then also that there was pain, and I was really unclear what was driving what. And I think what ultimately had kind of made me feel comfortable is that now the patient is on a regimen that is working really well. And it makes me feel, you know, now given that the dose that he's on a Butrans patch, it just seems kind of strange that they're doing well on such a low, you know, what is a low dose. But I totally agree that, you know, we're not advocating for folks to just use transdermal buprenorphine for treatment of opioid use disorder. So, you know, the other thing is that in general with these microinduction techniques, is when you're using transdermal buprenorphine for this, that the indication is not FDA approved. But that the same theoretical model for why we use transdermal buprenorphine to get someone onto Suboxone is the same as why we would use a low dose of a sublingual or IV buprenorphine. And that there are several case reports and case series demonstrating this as a successful approach. Here's a paper from 2020 that is, and the slides sent out has a link to the paper, and showing that this was one approach where someone was on hydromorphone and a fentanyl patch, and that they added transdermal buprenorphine, reduced the individual's hydromorphone over time, and increased and added on sublingual buprenorphine, and able at the end to have them just be on sublingual buprenorphine. And here's another approach from a paper in 2019. And the idea is you're going to slowly tape the individual off a full agonist opioid as tolerated, that you're going to start a transdermal buprenorphine patch, and then after 2 days, you're going to also start them on sublingual buprenorphine and increase that dose as tolerated. So, you know, the same principles that go for what Janet talked about earlier apply for why we're using the transdermal patch in this indication. And the transdermal patches are much lower than sublingual, so they allow for us to accomplish what many of the early papers showed that they did in Europe, because they have smaller formulations available in Europe of sublingual buprenorphine. So in general, you're going, like we said, you're going to taper the full agonist over the course of this buprenorphine initiation. Once you have the transdermal buprenorphine on, then after that, you can add the sublingual buprenorphine at a low dose and increase that while keeping this transdermal constant. And then you can take off the full agonist and take off the transdermal. What I think is the most uncomfortable thing about this for me was there was a point where the person was on a full agonist, a low dose of a full agonist, the transdermal patch, and a low dose of the sublingual buprenorphine. And so just having that many things floating around like initially made me anxious, but kind of knowing the direction that I was going and knowing that that this is grounded and a good reason to do this helped to make me feel more comfortable, and I feel more comfortable with it now. So from there, why don't we open up to questions and answer? I know we're at the top of our hour, so apologies for running late, but great discussion so far.
Zach, for the patch, for the Butrans patch, I've had experiences where patients had maybe misuse, but not in OUD. And I felt more comfortable putting them on Butrans for safety reasons. And I've had them take their last dose of the full agonist, like oxycodone, and put the patch on at the same time. And there's been no precipitated withdrawal.
Yes. Yeah. That's been my approach for if I'm going to just start someone on Butrans patch for chronic pain, is that I'll just have them take the last dose of their full agonist when they put the patch on. And that has worked in each situation.
The only question that kept coming up was whether we felt like buprenorphine had an analgesic ceiling. But
oh yeah, maybe I could. So I didn't mean to misspeak. I think that's a common concern that comes up because of this partial agonism effect. From what I've seen, like the studies looking at pain control with buprenorphine have not borne out that there is an analgesic ceiling. And so for patients on buprenorphine, for instance, one study looked at C-section, women with a C-section and who are on either buprenorphine maintenance treatment before or methadone maintenance treatment, because typically we don't think about methadone in the same way as having some sort of analgesic ceiling. And after the C-section, they looked at PCA usage for acute pain control, hospitalization stays, any adverse events, and they found that there was no difference. And actually, the patients with buprenorphine had actually less PCA requirements for additional full agonists for breakthrough pain when they were continued on their Suboxone. So based on animal studies, which also show that there's this potential to recruit additional opioid receptors in the setting of acute pain, as well as kind of human studies based on mostly patients undergoing some kind of surgical intervention who are either on buprenorphine or methadone before. I'd say that there's very low concern that buprenorphine has this analgesic ceiling. Now, whether, that doesn't to say that, for a patient with active cancer that's continuing to progress, I think it's still unclear whether buprenorphine can fully cover pain. But for most patients with chronic pain and for most patients in general, you don't have to worry about the ceiling effect. And so in practice, what I've seen is you'll try to maximize the buprenorphine for, say, a patient with cancer who's having active pain, adding full agonist as necessary for breakthrough until you reach a point where these adjustments just are not adding to additional symptom relief, and then can consider transitioning them to something that makes more sense for them.
Yeah.
I think we could probably answer this one question. I think about the Butrans analgesic effect as almost like opioid sublingually. Like some people will convince you that there's true absorption and some people will try to convince you there's an analgesic ceiling, but I wouldn't worry about it up front. It's not a reason not to put somebody on buprenorphine. But there was a really good question from Jonathan Rose about transitioning a patient from a fentanyl patch to Butrans, or how you would go about transitioning them to buprenorphine.
Yeah, so, and the Saul paper that that I have in the slide set, and I'll go back to show you. This person was on a fentanyl patch. So fentanyl is more lipophilic. One of the reasons to use microinduction, especially for people who aren't necessarily on a fentanyl patch, but are maybe getting fentanyl from purchasing fentanyl from non-medical sources, is the worry that even if you wait till someone have withdrawal symptoms and start that the standard dose of 2 milligrams or 4 milligrams, that you're still going to precipitate in withdrawal just because of how lipophilic fentanyl is. So using these microinduction processes, I think, for people on fentanyl, whether it's prescribed by a doctor or not, is really helpful. I haven't had anyone where I've gone straight from a fentanyl patch to a buprenorphine product. What I've done is started them on a short-acting opioid and then taken off the patch and given it a couple days, so they're on a different opioid for several days, just to make it that worked easier for this individual who was in the hospital at the time. But the case that I have up here, they used the patch put on when this person also had a fentanyl patch on. And so the same principle applies there, that the buprenorphine will slowly enter the bloodstream, and then the fat stores then displace the fentanyl. But really good question, John.
Another case in the Gauche article that's in the references where they used fentanyl patch as the bridge, and then slowly added Suboxone through microdosing as well.
Mm-hmm. And Becca had a question about psychiatric disease concern. And I would say that psychiatric, so there's, if we look at the opioid risk tool, there are certain psychiatric illnesses that make it more likely to be at risk for opioid misuse. And also thinking about some of the risk tools like STORM, there are certain psychiatric illnesses that put people at greater risk of overdose on opioids. So if I have someone who's on, I think it's case-based, and so there's not always a full, just because someone has a psychiatric illness doesn't mean that I'm always going to worry about how they're taking their medicines, but it certainly puts them at higher risk, and I'm going to ask more questions. You mentioned that this person with borderline personality disorder, and so my big question there would be, is there a past history of trauma that might be contributing also to pain? How big of a concern is impulsivity? And so those are going to be some of the things that are going to make me curious about kind of why we're using opioids in the individual, or if the way that we're using them is really the best way.
I guess I haven't personally transitioned someone from fentanyl onto buprenorphine. I don't know if Justin or anyone else who has some experience to kind of offer kind of more detailed recommendations about that transition.
Yeah, this is Justin. We have done it a few times, but if you're anything over a 12 microgram patch, it'd be really, really challenging to meet the pain need for the patient if that's what the focus is. 25 patch, you'd be pushing the limits of what you can do with the Butrans. But we simply took the 12 microgram patch off at night and put the Butrans patch on, and the next morning, and had no problems at all with either withdrawal symptoms or managing the patient's pain. We're pretty liberal with our opioid full agonist use when folks are on Butrans, and again, have had no problems with those kind of combinations. So in that circumstance, we would give them a little bit of PRN, low dose oxycodone or hydromorphine or something like that. But anything more than a 12 microgram fentanyl patch, you're going to have a really hard time doing it with Butrans, that's for sure.
Yeah.
I think that brings up, oh, sorry.
No, go ahead, Jesse.
Sorry, I was just going to say, maybe this is going to enter a slightly different topic, but I think that brings up the point that on top of buprenorphine, you can definitely use full agonists. And I think this crowd probably has an appreciation for that, but it's something that, especially if you're, consulting in the hospital or whatever, people are going to look at you like you're crazy, but it's like totally possible and fine. And, so yeah, you can definitely use full agonists on top of, buprenorphine. And I think, Justin, what I'm hearing you describe is a situation where you may be using it as a way to further kind of aid with the transition, realizing that going from 12 mics of fentanyl to Butrans is could be a big difference in dose. And that also seems fine to me, so I think just remembering you can use full agonists on top of buprenorphine products is really important.
Yeah. And we're going to that'll be one of our future calls will be dedicated to folks,
Right.
because there's always a lot of questions about that.
And
Exactly.
I would also add, if you're, it's sometimes very hard if you have sort of a mixed opioid use disorder and pain to actually know what the equal analgesic of buprenorphine will be, because
Totally.
I've had patients on 400 of morphine equivalents that are then fine on 12 of Suboxone. And so I think it's really hard. I've taken somebody off the patch, switched them to a short acting, and then put them on Butrans, and it's gone okay. It felt a little bit like I was guessing as I went along, but I really think that equal analgesic is something that I don't think about too much in advance, because I'm often surprised.
I could not agree more. I'm so glad you said that, because I was just thinking about this in clinic yesterday where, yeah, I mean, I had somebody who was on like a gram of morphine a day and he's on 16 total of Suboxone a day and feels the best he's ever felt, you know? And I think the cynic in me says that, you know, there's probably some component of like hyperalgesia that was contributing to how bad he probably didn't realize he felt on the full agonist. And, you know, just being on less opioid, making him feel like he said he felt like so much more energy, you know. So I think there's this perception that like, yeah, we want to do equal analgesic because they're doing so great on what they're on, but actually in this circumstance, they're not doing so great on what they're on. That's why we're trying to do something different. So yeah, I'm really glad you brought that up.
And it's also a reminder of just like so many of these equal analgesic studies were done with single doses and people who were using heroin. And so just like how different the drug supply is, how different it is when someone's on a chronic opioid, and then also just the contributing of like other sources of pain. But I just echo what you all are saying. Sometimes it just feels like the numbers make less and less sense the more I do it.
Exactly. Well said. Right. But it works, so don't worry.
It works.
It's
yeah.
okay.
Any questions? I know that we've run over, but I will encourage people to also email us. And for our next chat, we would really love to focus on cases that folks bring in, and we can do breakouts into small groups on Zoom and discuss cases, and then come together and have a lively discussion, and then we'll keep going with topics. But thanks everyone for joining us. This was a lot of fun, and we'll see everyone soon.